Hi everyone, my name is Yarelix Estrada and I am a harm reductionist in New York City. Um, so I'm going to do a presentation on some of the sections that I worked on for the Methadone manifesto, as well as share a bit of information about the methadone delivery system that I was part of at the beginning of the pandemic. So I'm going to share my screen to show my slides. And so the first section that I worked on in the Methadone manifesto was on racial disparities. And obviously the war on drugs has perpetuated in more ways than just the criminal justice system, and more just policing, literal policing, and also jail, but also in methadone clinics. And we're seeing this through increased surveillance, a higher requirement of UTOX tests amongst Black patients, as well as not providing appropriate or sufficient dosing for people of color. We've also seen stigmatizing perceptions around methadone maintenance treatment, both from client and for staff, which makes it difficult to have sustained use for people. A lot of people think that they have to get off of methadone because of misunderstanding or cultural barriers or stigma, like I named. And some of the recommendations that we have are for substance use researchers and treatment professionals to engage with the community, figure out where they're at, figure out what kind of education needs to be provided. So for example, there's a lot of stigma around Latino communities, Latinx communities, because they don't understand that there is the ability to use methadone long-term and have it not be damaging to the body. And so there needs to be more cultural awareness and appropriate education and engagement with the community. Additionally, clinics should conscientiously track data internally around race and drug screening and correct for the disparities that they find, as well as create a feedback mechanism for communities of color that access methadone treatment to change what the issues they experience in clinics, as well as for there to be more funding so that there are more harm reduction oriented clinics, as well as more trainings and resources to clinics that are in lower resourced areas, usually low income communities of color. I also worked on the disability section, and it was interesting to find that there were not a lot of research studies or a lot of literature around disability or the intersection around ambulatory disability and methadone treatment. And one of the few studies that were identified found that adults with disabilities were significantly more likely than adults that were able-bodied to have a need for treatment, and yet they did not. They had a lower level of treatment than those that are able-bodied. USU members have a wealth of experience, and they have named barriers like programs not having ramps for wheelchairs, bathrooms not having appropriate safeguards for those that have disabilities can safely use the bathroom, and their programs not having flexible hours to accommodate individuals that have to travel under special circumstances because of their disability. And there's a lot more that they named that you can find in the manifesto. So the recommendation that we have here is to listen to the voices of those that have disability and consider centering those voices when thinking about what future research studies will be pursued. And because there's a lot that's needed in this area, and there's a lot of information that needs to be filled in this gap that can be filled back, that can be circled back and fed to the methadone clinic so that they can better adjust their services. And also just increasing accessibility. So patients who are disabled should be fast tracked through the intake process, and they should be provided take-home medication quickly to accommodate various accessibility limitations that are complicated by COVID-19 and additional risk factors. And so the last bit, I wanted to talk about the methadone delivery system. The place where I work, which I am not representing at the moment, I'm speaking on behalf of myself, and I'm not representing this institution that I'm not going to name right now. We piloted a program that was interesting because we were executing the program while we were building the protocol. And to be doing that in the beginning of the pandemic, when we were, waking up to hearing 700 people died that morning or 800 people died in the city, it was really stressful to put together. But we developed a methadone delivery service to deliver methadone to patients or to people that were in isolation hotels, either because they had COVID-19 or were exposed to COVID-19, and also to people that had that, but had the opportunity to stay home. And so the hope and the desire from this was that people would have access to their medication, like they would have access to the life-saving medication that they've been using in a way that is accessible for them. And also to reduce overdose, because if people don't have accessibility to their medication, they may go out into the street and use whatever is available there. And with the adulterated supply that we are all very aware of, without having the harm reduction intervention supplies that they need, because they're in these particular settings, could lead to a higher rate of overdose. Part of this was also advocating for the delivery of all the doses to be given to the person, the individual whose medication it belonged to, as opposed to giving it to, you know, a gatekeeper like a nurse or a doctor that would hold on to it for them because that's their medication. So we advocated that it should go to them. And to date, beginning on the first day that we began doing the delivery system on April 2020 last year, until now, because the system is still going, people are still going out and delivering methadone. There have been over 4,600 deliveries. So I just want to shout out my amazing colleagues that have worked and are working tirelessly to continue the system going as coordinators to make sure that the whole system runs smoothly, so we know what person we're delivering to, so we know where they're located, what their doses are, fighting to have more, like an increase in doses if we can. Drivers and also delivery couriers that go in person and deliver the methadone. And these are Sadat Iqbal, Noah Hill, Alicia Rodriguez, Diang Severino, and Renee Nicholas. And that is all for my section. Thank you all so much. And I hope you enjoy the rest of the webinar.